We are recording. Thank you.
Okay, so I want to thank my colleagues for providing me the information that we're going to share tonight along with my talk. Throughout the talk, I refer to risk categories for prostate cancer. We don't talk about the staging as much in prostate cancer because it's the risk categories that define how we offer treatment. Treatment options are really determined based on the risk categories. And I'm not going to go through all of them, but you will hear over and over again tonight, low, intermediate, high risk. This is how we define where patients' prostate cancers exist. And again, it's these risk categories that are made up of three components really. Okay, the patient's stage, what is felt on examination, their Gleason score, which is what you see on a pathology specimen, as well as the PSA. And everybody's familiar with PSA. But PSA is not the only factor in determining should a patient have treatment and what kind of treatment they should have, but it does play an important role in helping decide where to go. So, starting the basics, we really have to understand what all these terminologies are. There's a ton of acronyms that we'll talk about. EBRT, IMRT, IGRT, SBRT, these are all technologies, acronyms that we use, and patients will often come to me and say, I want to have EBRT, IMRT, SBRT, just give me everything that ends in RT. And sometimes we can do that, but sometimes it's also important to understand what these terms mean. And we'll also talk a little bit about brachytherapy, because if you've had any exposure to radiation therapy or to the prostate cancer world, you'll know that there are different forms of radiation. So let's just quickly look at some of these. EBRT just means external beam radiation therapy. And it refers to delivery of radiation from an external source. Okay, it's really far away. Patient lies on a table, there's a machine, it rotates around the patient, and the radiation comes from a distance. IMRT is intensity-modulated radiation. It's just one technique of external beam radiation. And what we do is we really just adjust the dose as the beam comes out of the machine. IGRT is image-guided radiation, and that's one of the big advances today. I'll show you some images of what that looks like, but basically we're using our imaging techniques such as CAT scan, X-ray, ultrasound to define where we're treating. Hypofractionation and ultrafractionation, or extreme ultrafractionation, that defines how quickly or slowly we treat with radiation therapy. Radiation is delivered in fractions. When you go for a treatment, one treatment is called a fraction. Hypofractionation means just a very short amount of radiation treatments, and ultra-hypofractionation is typically 1 to 5 treatments. Brachytherapy is different from everything else in here. So we have external beam radiation. These are all types of external beam radiation. But brachytherapy is delivery of radiation close to the tumor or inside the tumor. So you may have heard of prostate seeds, high dose rate, wires. These are all forms of brachytherapy, which I will not be discussing tonight, except maybe to compare this SBRT to it. Okay, and the goal of these technologies is to improve what we're doing. So IMRT and IGRT, these have been advances in technology to take what we did 20, 30 years ago and take our technology upgrades and apply it to the world of radiation. And in doing so, we can go higher doses to get more tumor kill, but it also allows us to be more restrictive on our normal tissues. And what that means is less side effects. So higher doses, less side effects, better outcomes. So IMRT we talked about, that is adjusting the energy of the beam as it comes out of the machine head. And this is actually just a close-up of the machine head. And there are multiple little leaves in the machine head. And what that does is it tailors the shape of the beam to the patient's anatomy as it passes through. So if this is an image of the beam, these leaves rotate and they move in and out as the machine head rotates around the patient's body. And what you get are beamlets of radiation that deposit to a small area. IGRT, if we look at what image guidance has given us over the years, and again, these are one of the slide examples that you don't have to memorize, short of just saying, if we do better technology, we've demonstrated better outcomes. This is a slide from Memorial Sloan Kettering when they started to do this IGRT, so image guidance. We looked at CT while we were treating, and basically we saw less chemical failures. Sorry. I don't want to give away the ending. Less chemical failures and also less toxicity. And this was shown with every risk category as our technology improved. So tonight we're talking about SBRT. SBRT stands for Stereotactic Body Radiotherapy. And stereotactic means we're localizing stereotactically using markers or images or even the patient's anatomy, so that we're not doing a broad area of treatment but a very focal treatment. And we use the term body radiotherapy only to differentiate treating in the brain. So we could call it stereotactic radiotherapy. We also call it radiosurgery. We call it ablative body radiotherapy. This is a new acronym, SABRE. It's a very nice fancy marketing name. And also people call it ultra-hypofractionation. So what this means is we're taking our typical radiation dose that's been given historically over 9 weeks. We're taking that spread out dose, giving a higher dose per treatment, and in this case for prostate cancer, we're doing it in 1 to 5 treatments. There's been a lot of interest in SBRT for prostate cancer. And we have to look at why that is. Who can we give the radiation to? How does it work? Is there enough evidence to do it? So here's why it's become popular. It is very convenient. The standard radiation therapy prior to this has been daily, Monday through Friday, 5 days a week for 9 weeks. Okay, so patient is typically in the office for 45 treatments. Although it's short, it's about 30 minutes a day. The beam is on for about 3 minutes. Having to come for 2.5 months is a bit of a logistical hardship. This is a treatment that's given over 1 week or 1.5 weeks, and it's done in 5 treatments. It's accurate. It's very, very technologically driven, and there's a lot of planning that goes into making this very precise. We can give a higher dose per treatment, and that higher dose doesn't just shorten the treatment time. It takes advantages of the tumor's biology, and we're actually getting better results by going quicker. So we're not just getting the treatment done faster, although it is more convenient. It's actually been shown to be more effective. And it's also non-invasive, so we're really using that as a differential from doing a prostatectomy or even the brachytherapy, the seed therapy. Those are invasive techniques. This is all external. There is nothing internal in terms of radiation being given off. So there's been a rise in SBRT in New York. It's really sort of emerging and rising up a lot higher on this graph now in 2018 due to all these reasons. And just taking the information I explained and just kind of seeing in the chart. This, on this side, this is conventional. This is 45 treatments. It's pretty mild. It's very conservative. Over the last 10 years or so, we've gone to hypofractionation, taking this 9-week course and making it 5 weeks. And then recently, we've gone to what we call extreme or ultra-high dose, or ultra-high fractionation, is 1 to 5 treatments. So this is where we are today. Other options for treating, this is for localized prostate cancer, typically not for metastatic cancers. We'll talk about that, but there's a big difference. You could just do surveillance, and that's just active surveillance, watching patients, and that's for very early stage patients or very low risk patients. There are different forms of radiotherapy. You can do surgery. So you can have a radical prostatectomy, you can do a robotic prostatectomy, you can be laparoscopic. New emerging techniques include cryotherapy or cryosurgery, there's focal laser ablation, and there's even HIFU, which is high intensity ultrasound therapy. So these are all techniques that are out there. Some of them are FDA approved, some of them are not. So it's important to understand when you go for a consult, if you're diagnosed or somebody you know is diagnosed and they say, I don't know, I got 10 different options. Well, there are 10 different options, and you have to find the one that works best for you. But part of that is understanding why we do what we do. So a couple of these slides we'll just go through just to really show there is a plethora of data on dosing. And we didn't just go from a very low dose to a high dose. We had data, and we're talking about 10 to 20 years of data, and we'll show you some of it. But the question is, what does this mean? Is it faster? Is it better? Is it cheaper? Should we be doing this today as a new standard? So we already said it's faster. 5 treatments, 1 week, certainly fit. Can go over it ad nauseam. It's much quicker than 9 weeks, right? So it is also cheaper, and the cost is actually lower than what I'm showing here. Now it's more in the $15,000 range. And when we're talking about healthcare and financials, it's important to offer treatment that is less expensive and draining on the system if the outcome is going to be the same or better. So that to me is a win-win situation. And is it better? Well, I'll show you some of the data that shows that we may even have better results using this technique than some of the other techniques that we've been doing for the past 30 years. Here's your timeline. This is, as I put this together the other day, this is a slide I had for years. So the first patient was with modern hypofractionation. We're talking about going from 45 to 28 treatments. This was a big deal, and this was published in 1998. And it didn't really start to become a standard of care until about 1 or 2 years ago, and that's how long it took. So a 19-year span to become accepted as a standard. And at about the same time, the first patient was treated with 5 fractions. So we're talking about 18 years till we had enough data finally emerging. And I literally just updated this slide yesterday as newer data was reported that was very, very promising. And so it's becoming our new standard of care, and you'll see why. So I like to show you some of the early data, and people say, well, does it work? Well, how do we know it works? We have to look at the PSA. The PSA is our best marker for determining if radiation or even surgery has worked. There's some controversy as a screening tool, but it certainly is the modality for following after treatment. So that's what we use. This is early follow-up data. When I mean early, it's just because it ranged from about 2 years to not even 4-year follow-up. And that really wasn't enough to make it a standard of care. What we were seeing was the PSA was controlled, so no PSA rise after treatment for 99 to 100% of patients in the early data. Other data supported this. This was as we were going out a little bit more and more, we were starting to see higher number of patients, and now we're looking at risk categories. And you don't have to know these numbers short of saying we're in an 85 to 100% range of controlling the PSA. And that's a curative range. And this compares to very favorably to a prostatectomy. And again, this is with SBRT. All I'm talking about is 5 days of radiation therapy, not the 9-week standard course. So this was an initial consortium report. This was my friend at UCLA, and I'll show you the update that just came out this week. And they took 1,100 patients from 8 institutions, both in the United States and globally. And they followed them. At this point, it was only followed for 3 years, okay? And what they saw was that the survival at 5 years, looking at PSA, was that for low-risk patients, so these are patients with very early-stage disease, there was no biochemical failure. In other words, the PSA did not rise for 95% of patients. But it also didn't rise for 80% of high-risk patients. And that's data that's even better than we've seen for standard therapies. So you may know people who go on 9 weeks, they get hormonal therapy, something called androgen deprivation therapy, and their quality of life is somewhat compromised. When we go to these kinds of numbers, this is a great alternative for patients. And now the data is supporting it more and more. Another study that was presented in 2014, this was out of my colleague in New York, showed, again, 96 and 90% what we call biochemical free or relapse-free survival, and this one was at 6 years. So the data is slowly creeping up in terms of time. But the question is, all right, great, it works, but how toxic is it? So when I talk about toxicity, we talk about side effects, okay? And we use a scoring system. In the data that I present, when we keep saying, oh, there's no grade 1 or grade 2 toxicity, it's important to understand. You'll go to your consultation, and your urologist or your radiation oncologist will tell you there's no grade 2, 3 toxicity, and everybody is nodding, but nobody really knows what that means, and nobody asks, what does that mean? Grade 1 and grade 2 toxicity, whether it's for urinary or for the GI, is really kind of what we call toxicity or side effects of nuisance, right? You can go more often Sometimes you have some burning, sometimes you have diarrhea, or when you get to a higher grading, such as 3 or 4, that's where you start to see real problems, such as blood in the urine, blood in the stool. You can have obstruction, perforation, bleeding. We don't want to see these grade 3 or 4 toxicities. That to me means the trade-off of giving a higher dose or a faster dose isn't worth the side effect outcome. And in radiation, that's what we're constantly trying to do. Increase our dose while decreasing our side effects. So first, let's look at the physician perspective, right? Let's look at the data that physicians are reporting. And here, in the early outcomes, we saw higher toxicity scores. Back in 2009, there was toxicity of 50 to 65%. And I'll present a little bit of newer data, but as we got a little bit more advanced in the technologies, those numbers started to come down, but still in the upper single-digit percentage, so quite high. But this is the newer data, and what you can see here are numbers that are extremely low. This is SBRT, right? This on both sides. So this is urinary, this is GI, like colorectal, and those toxicity levels are significantly low, mostly under 10%, some of them in the 1 to 2% range. When you compare that to just standard external beam, or even brachytherapy, so those are other treatment options, the SBRT data now significantly better or the same in some categories. But why don't we just keep going higher in dose then? Maybe we'll get 100% cure rate. Well, this was a colleague out of Southwestern, and they went high in dose, and what they found were really unacceptable toxicity levels. And we're thankful that they do these trials so we don't have to do it on our patients. But it's important to understand that we have limitations, okay? So here was a dose that we don't go to because the grade 3, grade 4, remember that's on the right side, was way high, and that even 5 and 6 patients who got treated to that dose required colostomies. We don't see that today. In the dosing that we go to, it is extremely unheard of to see those kinds of toxicity scores. But that's great. That's the physician perspective. How do patients feel about this treatment? Okay, so there have been multiple trials, but this was a big one. And EPIC scores are a survey, and we give surveys to our patients, and we follow them routinely. And it's a questionnaire, and these questionnaires ask very specific questions regarding urination, regarding bowel movements, regarding sexual function, and it's used universally. So we all report those same exact side effects based on these scores. And this was a very good study because it compared standard 9-week external beam radiation to SBRT. Now this is looking at urinary incontinence. And those numbers are actually quite low and pretty much the same. And that's true of brachytherapy. So the brachytherapy is the seed implants. This is looking just urinary irritation and obstruction. And again, quite very similar, maybe even slightly better with SBRT. And here's the rectal and bowel complications. And these numbers are very similar as well. And now, at the end of this talk, I'm going to show you some brand new techniques we're doing that are taking these complication rates in the bowel and rectum to less than 1%. But are patients potent after SBRT? And that's a big issue for our male patients that are potent before their diagnosis of prostate cancer. So similarly, we looked at EPIC scores for sexuality and function, and they're really relatively the same regardless of what treatment we do with radiation therapy. And these numbers actually fare quite well compared to surgery, and they may be even better. So it's a good option for patients. This is just showing you again, it does decline a little bit after radiation, but the numbers are very comparable and slightly better than even surgery today. So another important way to look at this is how do patients actually feel? And it's okay to look at these surveys and score them, but were they happy after the treatment? And I think this is a great way to follow. And this was a big study that compared SBRT, brachytherapy, and external beam radiation. And the SBRT group did really well in terms of asking short-term side effects, long-term side effects. And most of these patients had less side effects than they actually had expected to receive. And some of it is their communication with their physicians, but whether they had SBRT, IMRT, or high dose rate, that's the brachytherapy, the SBRT did actually probably the best out of all three groups. So when you looked at these numbers, about 20% of patients in both the IMRT and the brachytherapy group had regret after treatment, compared to 5% with the SBRT. And that's really significant. So that tells us patients like this form of treatment. So some of the newer data we'll fly through. Basically, we're getting to modern data showing that this works. And it's also showing us our toxicity scores, okay, side effects, are now down to 2 to 5%. And that's really low. I mean, we're treating with a curative approach in 1 week without the side effects of surgery, and we're really doing quite well with that. This is a trial that's actually ongoing. I'm just showing one slide of this. So this is going to be a randomized study comparing surgery versus SBRT, and I think it'll answer a lot of questions for us. So let's just look quickly at the techniques. I'm not going through a lot of this. Most of this is just to show that SBRT does just as well, if not better, than what has been considered the standard treatment. But what does it cost? This is standard 9 weeks radiation. This has been our standard for 30 years. Although IMRT is a newer technology, 20 years, it's significantly higher than the SBRT number. Okay? It's pretty obvious in here. But what about patients getting active surveillance? They're not getting treatment, they're being closely monitored. Well, they start low. It's just monitoring with PSAs. But as they keep getting monitored, tends to lead to more biopsies, MRIs, and ultimately is a percentage of patients that will go on to treatment. And when you look at those numbers, there's a higher cost burden with active surveillance than treating earlier with SBRT. Today, these are the Nccm Guidelines. This is what most of the physicians refer to see what is considered a standard of care. And this grouping here, these are our SBRT doses. So a year ago, this did not exist. The report said, this is experimental, it's not for prime time. And today, it's prime time. So I talked about the earlier stage diseases, the earlier risks. Can we use it for high-risk disease? We can. In fact, the numbers are even better than for standard therapy. And this is just flying through. This is a high-risk study. 70% of patients in the high-risk group had biochemical free survival at 6 years. Compared to standard therapy, that was about 65%. And I'm going to show you the newer data that's actually been higher. So people say, well, there's problems with it. There's always people who are going to criticize, and rightly so, because we need to always challenge what we're doing. So is this enough follow-up to make it prime time? Is it effective? Is it toxic? And we went through the side effects. But we consider this new and unproven. And I come back to brachytherapy. And a lot of people, when I talk about radiation, 90% of patients in the room, or people in the room, they know seed brachytherapy, or the term seed therapy. And 10% know about SBRT. Well, brachytherapy was considered new and experimental, unproven, just about 20 to 30 years ago. And it took that long until that became a standard of care. And while that was becoming a standard of care, we started to do more and more SBRT. So the problem we have today is our technology grows so quickly that by the time something is 10 years out, becoming the new standard of care, we're at 2, 3, 5 years for the next technology. So at some point, we have to look at where do we follow up the patients and say, we need to start doing newer techniques. So this is something that we're starting to employ for all our patients, but we are doing it for SBRT, where we're monitoring the patients real time. And what we're finding is that if we go faster and if we monitor closely, we have less side effects. This was a paper I had just put out when I was back in New York, where originally, if you hear of a CyberKnife treatment, for example, for radiosurgery, their treatment time takes 45 minutes to an hour. That's how long the beam is on and while the patient is being treated. With this technology that we've been doing, at the time that I put this together, it was 8 minutes for treatment, and now we're down to about 6 minutes of beam on time. You're in the, what's that? We use an Electa. Other people use Varian. Those are the two biggest machines that are out there. It doesn't really matter so much about which machine, but there are some nuances in some of them that allow the dose to be delivered faster. So we're talking about a 5 to 6 minute of beam on. It doesn't mean you're in the office 5 to 6 minutes. You're typically there for a half an hour to an hour to be in the prep position, but it's very fast under treatment. Again, improving our techniques. We do image guidance. And I want to just kind of bring us up to speed. This was a big week for radiation oncology because our large international conference just took place, and it's currently taking place in Texas. And the newer data, which was new up until this week, has now become the newer data. And it's really important to keep up to see where we are. So you're getting the hot off the press stuff. This was presented earlier this year, and this was a multi-center trial for low and intermediate risk patients. Follow-up was 5 years, and we're looking at now, remember we're seeing numbers of 85 to 95%. So this is a 5-year survival of 95 and disease-free survival rates of 97%. Those are curative numbers. These are numbers we see with prostatectomies where we don't have to remove the prostate. And when we started to look at favorable intermediate risk group patients that before was 85%, we're now at 100%. So that's not across the board, but we're looking at numbers 95 to 100%, and with toxicity levels of 1 to 1.5%. This was the update. I kind of blew through this quickly before to try not to bore anyone too much, but this is the big Scandinavian trial. And in this trial, they had intermediate and now high-risk patients. And these patients did not get hormone therapy. They just got straightforward radiosurgery or standard radiation. And what we see here now is an 84% biochemical-free survival with just 5-day radiosurgery. Compare that to what has been the standard, which is about 65% for 9-week treatment combined with hormone therapy. So that's a real difference in terms of convenience for the patient, but to have a great outcome. This is the newer data. This literally got presented the last 2 days. This was a large group of patients treated with low and intermediate risk disease. This is 2,000 patients. This is an update from our friends over at UCLA. And basically, similarly, at 7-year follow-up, we're talking about numbers in the high 80s to mid 90s. Okay, so this works. This is a program that I launched at St. Jude earlier this year. We didn't have it before because I was in New York before. So we started a program that was very precisely put together to decrease side effects, and I'll go through some of the techniques that we've been doing in order to make it precise. Every patient gets an MRI and a CAT scan for our planning. Okay, that's kind of a newer technique that should be employed for SBRT. We do it on all our patients. The MRI is better image quality, and it gets literally fused to our CAT scans. So our CAT scan is used for planning, our MRI is used for planning, and we fuse that, and that allows me to see the prostate very clearly. We put a very small margin around the prostate. By a margin, I mean the dose that's going outside the immediate prostate. So the rectum and the bladder are the two adjacent areas, and that allows us to keep that dose really low. We target and we monitor the patient real time, and we have a whole prep for the patient in order to make sure that we have consistency. These are numbers we look at. So after a patient comes in, they say, well, I want to start tomorrow. I said, but we can't start tomorrow. Just like we have to prep for surgery, we have to prep for the radiation after our planning. We have to meet every single one of these constraints to every single one of these organs, okay? And these are constraints that have been put together through the years that we know that if our planning meets these numbers, the risks of side effects are extremely low. And if these numbers are higher than allowable, we don't do it. When the patient's on the treatment machine, we have our planning CAT scan, and there is a CAT scan on our actual delivery machine. And what we do is the image is captured and they're fused. So patient is on the table, right before they get treatment, we fuse the images. So this is, the darker gray is a planning one, the lighter gray is the one on treatment, and we fuse them and we can see them overlap. So if you can't see a difference, it's because it's exactly on. And this is one of our patients, and we also check them with x-rays. We do this before we turn the machine on, and we do it in the middle of treatment just to verify that we're treating exactly in the position that we plan them to be treated in. So there are some other technologies we can help move things along. There are different types of machines. People always ask me, well, do you just do the tumor or do you treat the entire prostate? And I always come back to surgery because prostatectomy has been sort of where people know their comfort level. You don't remove part of the prostate for cancer treatment. You remove the entire prostate. And we do that with radiation therapy. And the real reason that we have been doing it and are doing it is because when you have a prostate biopsy, they stick a needle in usually 12 cores. They stick it in 12 spots. And it could be blind, it could be under ultrasound or MRI guidance. But if you think about the size of that needle, it's millimeters. Okay, so they're drawing out millimeter cores. And when one comes back positive, really don't know what's 1 millimeter away from there. And in fact, when they looked at autopsy specimens, there was a significant number of patients that had much higher grade tumors on autopsy than what they found on biopsy. So we don't want to leave that area untouched. And we treat the adjacent seminal vesicles, so we get a nice margin around there in case there's tumor outside of the prostate. We monitor patients real time. And now the list isn't moving. What we're seeing is basically a 3D topography image of the patient during treatment. And we set thresholds. So if the patient is moving during treatment, currently we have the ability to turn the machine on and off. What that allows us to do is not treat outside the area so we don't miss our target. There's a bunch of different ways of doing that, and this is an example of as the patient moves through, this is the amount of movement they have, and this is what the therapist is looking at. They have the ability to turn the beam off, and where we're going in the future is the machines will have the ability to move with the patient, so you don't have to stop the treatment. So I'm going to finish up with hopefully some non-boring slides. I like to throw in a lot of images to kind of wake people up towards the end. The issue with side effects from radiation is that we have organs right next to the prostate gland. This is a side view. Okay, here is the prostate, here is the bladder sitting just above it, and here is the rectum. And this is the only space between the prostate and the rectum. And it's about 1 millimeter, maybe 2. When we treat with radiation, we get this whole area. We put a margin in. So what has been developed, and this is a technique we're using on nearly all of our patients, is introduction of a hydrogel. Okay? So under local anesthesia, patient gets this area numbed, and we insert a needle, and we inject a liquid. And within about 9 seconds, this liquid forms a gel. And what that does is, so this is what we call an axial view. So you're looking through the patient. If this is the prostate and this is the rectum, okay, this distance becomes this. Now we have a space here. So when we deliver the radiation and we give a high dose around the prostate, if you imagine the rectum being right up against here, well, you would get about 25% of the rectum getting a very high dose of radiation. With the introduction of the spacer, that high dose region is completely away from the rectum. So what we're seeing now are toxicity or side effects to the rectum of less than 1%. And that's a big change because we're giving higher doses faster with less side effects. This is an MRI view. So this is an actual patient. Here is the prostate, and then here is the prostate. Here's the rectum, here's the rectum, and this bright area is the spacer. So you can see that now there's a big space in between the prostate and the rectum. When you give a radiation dose, imagine this circle, that high dose falls into the spacer and not the rectum. And what happens is after about 12 weeks, the spacer gets just completely reabsorbed by the body. And this is an MRI image showing that. So here is before, here is normal anatomy, here's the spacer, and you're back to your normal anatomy after typically 12 weeks. What this has done, and we follow this graph, years ago this was 3D treatment back in the 90s. We went to IMRT. This is where we modulated the dose. We started to get less dose to the rectum. And then here is a sharp drop of dose to the rectum because we introduced this spacer. So this is a game changer in the radiation world. I use them on my 9-week IMRT patients, but almost all of my SBRT patients get it. So I just wanted to show you what we look at when we do our planning. Radiation is a very dynamic field, so imagine how quickly technology changes. If you think about what your computer looked like in the 90s, or a cell phone, if we had cell phones in the early 90s, and where we are today, the same kind of technological improvements happen very quickly with radiation therapy. So this is what we see when we plan a patient. And these fine lines represents the beamlets of radiation as it goes around the patient's body at 360 degrees. We look at it from an axial view, from what we call a coronal head-on view, and also from a sagittal or side view. The blue is the rectum, and we see a 3D version of it. This is the prostate, and this is the spacer. So we can see in all dimensions and directions which way the beam is coming in and what it looks like on the patient. And we see 3D renderings. This is our beam's eye view. This is a transverse view, so we can see this is a representation of the patient on the table. But this is all seen before the beam is ever turned on. We then look at every single dose structure. If you remember that big chart I said we have to meet each constraint, we look at the dose and we look at the percentage of each organ getting that particular dose, and we make sure that we fall within those acceptable numbers. This circle and these, what we call dose clouds, this is the dose to the prostate. And you can see within millimeters away, there is no dose. This is a nice, tight, conformal treatment, and all of the dose is concentrated within the prostate and a small area around it. We're starting to do it for high-risk patients. There's a few protocols that are out with UCLA and Memorial, and we're doing them as well. And even for patients with metastatic disease, and I just threw in kind of one slide, I have patients now who have metastatic disease, meaning it is spread outside of the prostate. It could go to the bone, it can go to another organ. And years ago, these patients would just put on hormone therapy or they received palliative care. And what we found was that if we treat the prostate, okay, so we're treating the epicenter where this disease is coming from, patients actually live longer. And that was actually just updated today, and I haven't even updated my slide, literally today. So there is survival with metastatic disease for prostate cancer. So just to conclude, SBRT, it's faster, it's cheaper, and it's potentially better than treating with other forms of radiation or with other techniques for treating prostate cancer. It's the next step in the evolution of treatment. It's replacing conventional therapy. That's the 9-week therapy. It's already acceptable. Gave away the ending. It's already acceptable for low and intermediate risk patients. I showed you data for high risk patients. There's so little toxicity today compared to where we were. It's safe, it's effective, it's quick, it's less resource intensive, and I think where we're going is this is the new standard of care for treating prostate cancer. So this is a typical machine. This is what I explained in the machine, how it rotates around the patient on the table, and this is what we get when we follow the patient. And that's it.
What patients would you not do SBRT?
So when I see patients, the first category that's a challenge is high-risk patients, and that's why we keep talking about low and intermediate. Although it's approved, okay, it's not considered experimental, the high-risk long-term data do not exist yet. We have 5-year data that shows it's better than standard therapy, but we don't have long-term data. Does that mean I won't treat the patient? No. It means I have a discussion with the patient. The patient has an option to still get this treatment. And the reason being is if I see a 78-year-old patient and I say, look, I have 5-year data, and that 5-year data is saying 85% of patients aren't going to have recurrence. Well, by the time they're in their 80s, if they have a recurrence, focally or outside, we could address it, okay? I don't know that a 75 or 78-year-old patient wants to go through 9 weeks of therapy, so I do offer it. The second category of patients that we struggle with are patients that have a lot of side effects from their prostate cancer. So if they're having a lot of urinary problems, we could potentially make that worse. Although the side effect profile is very low, we're still adding on. And this is a discussion I have with the patients. So we're talking about, am I offering them the 5-day course versus the 9-week course? Those lines are blurring. As I showed today, the toxicity for SBRT is really coming down and is better than some of the 9-week course. So I have very few patients at this point that I cannot offer SBRT. And this is for localized disease. Sure.
So is SBRT approved for most insurance?
It's, yeah, I don't think we've had any patient not approved today. The one challenge has been high risk. Not every insurance company will cover high risk. Medicare does. So for the majority of my patients, they're in the Medicare range, although I'm starting to see patients in their mid-40s now. But I have not had an issue getting patient approved. Ken works with me at St. Jude, so I'll look to him.
You mentioned age. Is age a factor when you treat with SBRT?
Well, age used to be a factor for us when we considered that we didn't know the toxicity. But when we saw that the toxicity levels were coming down, it actually makes more sense to offer for elderly patients who have logistical issues coming for 9 weeks every day. So it is no longer, in fact, it's quite the opposite. When I see an elderly patient, I'm more inclined to go with SBRT because I have a better chance of getting them through their whole treatment.
Would you care to define elderly for us?
No, I don't care.
Oh.
Well, listen, it's evolved. As I saw my 96-year-old patient who came with his 93-year-old college sweetheart the other day. I put him in the elderly category. I typically, we say mid-70s at this point. But I've never dismissed a patient based on age. I did have a 93-year-old consult the other day, and I told them that he would probably outlive his prostate cancer. And in his mind, he was the 93 is the new 73 patient. And in his mind, he was not comfortable sitting on that, literally. And when he knew he had a 5-day treatment option, he decided on treatment. And these are the patients who, if you said you need to come every day for 9 weeks, they wouldn't be comfortable. But I don't dismiss based on age, but I do have a conversation with the patient. Now, if I see an 85-year-old patient and they have diabetes, heart failure, pulmonary congestion, hypertension, their prostate cancer isn't going to be what does them in. And I try not to recommend treatment at all sometimes.
What's the future for using SBRT for metastasis?
Well, actually the future is here for that, okay? So for patients that have an isolated lymph node metastasis, we do SBRT. I've done this routinely on patients. So we don't, as you saw, we treat just the prostate typically, unless there's disease in the lymph nodes already, and that's another scenario. I'll explain that. But I have treated patients that had either conventional radiation or prior SBRT or prostatectomy, and years later they had an isolated lymph node. And the standard has been to put these patients on hormone therapy. The problem is hormone therapy has a lot of side effects, and sometimes unbearable side effects. And nobody knows how long to put patients on hormones. Sometimes we put them on indefinitely. Sometimes we put them on for a year, 2 years, 3 years, stop, we pulse it. But with radiosurgery, if there's no evidence of other disease, I've treated isolated lymph nodes for 5 fractions with long-term duration. I have a handful of patients now out 5 years with no evidence of disease. And these are patients that refused hormone therapy. They were in their early 80s, and now they're alive in their mid-80s or late 80s without disease. When a patient presents with lymph node involvement, there's always been a question of whether or not we should even radiate, but there's more and more data showing a benefit. I kind of quickly went through one slide where we are offering SBRT now in select patients to the entire pelvis area and the prostate itself. So we're doing it, most of us are doing it on study. I've done a handful of patients off study for logistical reasons. There's not a whole lot of data on it in terms of side effects, but there's a lot of data on it doing that same technique for rectal cancer. So if we apply that data, I think that's the future of where we're going to be, even for lymph node positive disease.
If you had biochemical recurrence after ADT, are you saying you still do SBRT? If it's coming back?
If it's come back in the prostate, and
localized
but what kind of initial treatment?
ADT, antigen.
Just ADT? So most patients are only put on ADT alone if they have metastatic disease. So that's a tough question to answer. If they've been put on ADT and everything has come down, the way that I would address a patient like that is I'd have to rescan them and see why did the PSA come back up. And PSA is an antigen. It's a protein that's produced by prostate cells. And these could be prostate cancer cells, normal prostate cells, and they don't go up after treatment unless there's a group of cells that are producing this antigen. So we need to find out where that is. Oftentimes, after androgen deprivation, we'll find an area, it's typically a lymph node, sometimes it's the prostate itself, but if I can localize an area of failure, I can offer SBRT to that area.
Are there any recent studies that show how much GY is optimum now for least toxicity?
Yeah, so I kind of quickly, and we call it gray. Gray are our units.
Gray because it's from 33 to 40 radiological.
Right. So we look at dose escalation studies, okay, and some of the earlier studies using CyberKnife were going to about 35 gray. In fact, my first group of patients I went to about 35 gray. And that those numbers have come up, and typically now we're at about 40 gray in 5 fractions. So the number of fractions also plays a role. I had that one quick slide from Texas, and they went to they did 10 gray times 5 fractions, so a total of 50 gray. And the side effect profile was way too high. There was a recent study looking at taking that same dose and giving it in 3 fractions or 4 fractions. 4 fractions actually has been very promising, so 9 gray times 4 fractions. But right now, across the board, most people are doing 8 gray times 5 fractions or 40 gray total, because we know the toxicity profile. What happens is more and more studies are going to be done. People.
I noticed reading a study by Katz.
Yeah.
I think he does about 35 grays. I know Dr. King does 40
Yeah.
grays.
So Alan Katz was actually my colleague back in New York, who, when I launched my first SBRT program, he had presented his data. Those were data looking at CyberKnife technologies. And the way the dosing works with CyberKnife is you're giving a high prescription point. And so the prostate itself was actually getting a higher dose than what's presented there. He has since gone to 40 gray as well, because the numbers really weren't as high as we'd like to see. But it really depends on the patient. A lot of it is the technique. So Chris King at UCLA, who I also formulated my program off of, he does 8 gray times 5. Memorial Sloan Kettering is at 8 gray times 5.
Do you do it every other day, or could you do it consecutively?
I do it consecutively. There isn't a consensus out on whether consecutive or every other day makes a difference. Some people do every other day because they are worried about toxicity, but when we show the data, it's kind of mixed across the board. The only time that I have gone to every other day is when patients have very, very, very large prostates. And when they're over 100 grams, that means there's a lot more bladder or rectum in the radiation field. So I want to take every precaution to decrease the side effects, and in that scenario, I may go to every other day.
You say you use a spacer.
Yeah.
Are you atypical among other radiation oncologists who administer, or is this standard?
It's mixed. It's really mixed across the country. I was using it first as an off-label indication back maybe 5 years ago, before. It was companies called Spacer. There was a product called Duracell. And we did our first few cases, and then this became FDA approved. It's hard to say. If you're at a very progressive institution, they'll be using it. But not every place does it. So I talked to Chris King at UCLA. He does not use Spacer. But that becomes an art.
It's new technologies that people...
Yeah. And it's also what you're accustomed to doing and seeing and planning. To him, if he's getting these low toxicities, he doesn't feel the need to introduce another substance.
I just missed when you were talking, do you do hormone therapy before administering?
Okay. You didn't miss it. I kind of skirted the issue because it's still controversial. So for low risk, no hormones. For favorable risk, no hormones. For intermediate risk and high risk, the data are not out to suggest that we can omit it, although the data I presented today for high risk was without hormone therapy that showed an 84% biochemical free survival. That being said, there's only 2 studies that have shown that. So for my patients, unless they're on a clinical trial, and UCLA has a clinical trial, they're not offering SBRT high risk without enrolling in the trial. Now, if you're in the trial, you may get hormones or you may not get hormones, but that's just part of the trial. When I see my patients, I discuss this with them, and I talk about what is standard of care versus not standard of care. So I've had patients who say, I understand that, and I understand the data, but I do not want hormone therapy, because hormone therapy are not without side effects. But that's with an understanding that we don't know whether hormones will add to the benefit of SBRT or not.
I'm considering getting SBRT in the near future, perhaps, maybe. And my doctor says I may need a TERT.
Okay.
Now, if could I get if I had SBRT without having a TERT, would the prostate atrophy and perhaps a TERT won't be needed?
So let me do the disclaimer first. Without seeing everything about you, it's hard to answer that. That being said, I can tell you that I've done patients who've had symptoms and the prostate, yes, is atrophied. After SBRT, the prostate doesn't shrink and get hard. It actually shrinks and gets very soft, okay? So when you do a digital rectal examination, you can barely feel the prostate. And that's why one of the terminologies is ablative therapy. Sometimes it will mean less urinary outflow issues. But if a patient has a lot of problems now, and we do radiation, we cause inflammation, we cause some side effects, it's possible it would go the other way. And the way that I would answer this is to understand why a TERP would be needed in the first place, and what is the cause of the urinary symptoms.
It's like, the prostate is laying on the urethra.
Yeah, well, the urethra gets a dose from the radiation. But I would say you can come in and see me and go through it in detail. I don't want to discuss your case in front of everyone. Yeah. All right, any other questions? All right, well, thank you all for coming. Oh. Wait.
When I was at UCLA, Dr. King used water, used a lot of water.
Yeah.
A lot of water. Any relationship between the use of water and the use of this?
Well, the purpose of the water, and we all do it, we all follow very similar protocols, is to fill the bladder up, to be one, reproducible daily, but also it pushes the small bowel out of the radiation field. So we do it. If you imagine your bladder being extended, and also you get less dose to the bladder, if your bladder was empty, it would be flat like a pancake. And you would have most of the bladder in your radiation field. And you would get an unacceptably high dose to the bladder.
Is there a special diet that you recommend during treatment or not?
Yes. We typically do low fiber diets, low gas diets. Remember, we're talking about 5 days. The purpose of that is reproducibility. Okay, don't want gas distending the rectum. Okay, and we also don't want a lot of stool in the rectum. Those are things that are going to move where the prostate is. It's also going to move the rectum in and out of the field. So It's less of an issue for a 5-day course. When we do our 9-week course, it's a problem and patients have to change their way of eating. We do an entire teaching with our patients for what to eat or not eat during the radiation.
I think Dr. Peter didn't have to do a special diet.
No, but typically, if you move your bowels every day and you're not constipated, we don't have to do anything special. But we definitely recommend low gas foods. So beans, broccoli, cabbage, spices are out. But they're only out for a week.
How about vitamins?
Well,
Is that a bad thing to have?
during radiation treatment, we typically avoid high doses of antioxidants. So regular vitamins, it doesn't matter, but vitamins A, sometimes C, that's debatable, E, magnesium, selenium, coenzyme Q, those should be avoided during treatment.
Selenium should always be avoided for prostate.
Well, there's debate on whether or not we should have an antioxidant for prevention, but I don't steer my patients away from it, only during treatment. Okay. All right. Well, thank you very much.
Thank you.
My pleasure.
Thank you, Dr. Farber. We hope that you enjoy your first winter in Southern California.
So far so good.
Thinking of how things may get back in